Thank you. I am delighted to be here. This is my first time in Kuwait, and for a man who was born and raised in Canada, it's a little warmer than I'm used to. I'm not built for this much sun. I go outside in Kuwait for 2 minutes and I sunburn. 2 minutes. But I make vitamin D very, very quickly in Kuwait. I am thrilled to be here. I appreciate the invitation. And my goal, I'm a scientist. I study metabolic disorders. I study in particular type 2 diabetes, its origins, and what it does. And that means we're going to be talking a lot about a small, teeny little hormone called insulin. And I hope if there's any questions that come up, please, I would love to answer questions. I'm mostly a scientist in the lab doing experiments, but I'm also a professor, so I love good questions. So if you have any during the course of this, please take a note, and we'll see what we can get to. So as a scientist who studies disease, as physicians who treat disease and want to understand, we could look at any number of diseases around the world, you name them, any chronic, non-infectious sort of disease, and we would be able to find many types of causes. Now, as you know, of course, diseases are complicated. Some are more complicated than others, but you might have, in one instance, one disease has two known causes, but these two same causes may cause two completely different diseases, and then any other mix of cause with disease. Now, my aim as a scientist, why I study insulin resistance, as I'm going to show to you just a little bit today in the time that I have, you can pick any chronic disease, and insulin resistance is going to somehow be connected to it, in big ways or not as big. But the reason it's important to me, why I've devoted my career as a scientist to understanding insulin resistance, is that when you appreciate that insulin resistance has is in the origin of many chronic diseases, you can just simply attack one single thing. When you know you have one target, like insulin resistance, you can start to fix lots of things, especially when it comes to metabolic health. So, why have a scientist like me come all the way from, I'm in the US now at a university at BYU, Brigham Young University, no alcohol, so I'm right at home in Kuwait. I don't drink alcohol, I feel like I'm at home. So why bring me all the way to the Middle East? Does it even matter? As you have amply been shown today, this matters more. Me saying what I'm about to say in the next 25 minutes matters far more than anywhere else. Diabetes, insulin resistance, which is what I focus on, matters more here than anywhere. Very briefly, you've already seen this. If we look at the top countries worldwide, look at the first 9. Isn't that amazing? It is. It's shocking. And then you have Mexico, but even still we're sort of staying, then we leave this area of the world, but you can see that this is a problem. And I don't need to show anything more than this. This speaks 1,000 words. You know it's a problem. I like the idea of trying to move things along and get the conversation going where it needs to get. And as bad as it is now, it's actually potentially going to get much worse, where we see that it could be doubling in Middle East, North Africa in the next 20 years. So a double. As bad as it is now, it will get that much worse. The next generation is going to be carrying these problems. So let's, as physicians, you really are the ones who are building this, helping solve this problem by building solutions. And my goal, and collectively the goal here, is let us help you with some tools. The tools that I can give you are just the things you can think about when you're interacting with the patients. Because I'm not a physician, I'm a scientist. You can do what I can't. Now, these are statistics that I just showed you with type 2 diabetes in particular. Now, why then am I talking about insulin resistance? Let's look at the disease. Type 2 diabetes is a disease of too much glucose. That's how we clinically define it. We only look at the glucose. But unfortunately, we never look at the insulin. Never. That's not part of how we typically clinically look at type 2 diabetes. We define it as a disease of glucose, which is totally wrong. It is a disease of too much insulin. When you look at it as a disease of too much insulin, you catch it long before glucose changes. Because insulin resistance is the foundation of type 2 diabetes. And insulin resistance happens when the patient is still normoglycemic. In other words, you have normal glucose levels, but insulin has to be much higher in order to keep the glucose normal. Does that make sense? The body's working harder. We'll look at that more in just a second. But any person with type 2 diabetes is insulin resistant. That is a disease of insulin resistance. It just gets so bad that insulin can't keep glucose in control anymore, and then the glucose climbs. Then we catch the disease, 10 years after insulin was elevated. So prediabetes is another term for insulin resistance. It starts as insulin resistance and then progresses to type 2 diabetes. So my aim, I want to make sure that any health practitioners, physicians in particular, have an appreciation for what insulin resistance is. So what is it? Let's get right into it, and let's go right down to the level of the cell, which is where I conduct most of my experiments as a scientist. So if we look at what the cell is doing to insulin, insulin does lots of things. It does hundreds of things. Just looking at it as something that lowers glucose, it isn't fair. Insulin has lots of talents. Lowering glucose, pulling in glucose is just one of them. So let's just define this as a cellular action. When insulin binds to a receptor, like knocking on a door of a house, we have something in the cell happening. We'll just call it a cellular action. Over time, however, as the cell becomes insulin resistant, this action is diminished. It doesn't work as well as it used to. And that's a problem for the cell. You can name the cell. There are insulin receptors in every cell in the body. From the top of the head, mine's just shinier than most, all the way down to the bottoms of your feet. There's insulin receptors on every cell. So various cells will become insulin resistant in various ways, but the similar strain is that something is different. The cell isn't acting the same way because it's just not responding the same way. And so what does the body do? If this much insulin isn't enough to get the same action as before, what will the pancreas start doing? It'll start producing more insulin. And now, of course, we have hyperinsulinemia. But most people don't measure insulin, so they never know it. But you can get it measured. So now the body has this much more insulin. Now we have, rather than just politely knocking on the door, insulin, a lot of insulin molecules are pounding on the door. And now we're able to restore that action to some degree, albeit it's still not the same as it was before. So there are two key things to take away when you want to think of the definition of insulin resistance. One is that cells no longer respond the same way to insulin like they used to. It's not working quite the same way. And two, and this is important, there's a lot more insulin in the blood than there used to be. Hyperinsulinemia. Again, tragically, we usually don't ever catch it. We never measure insulin, even though type 2 diabetes is a disease of too much insulin, not too much glucose. All right, so what are the causes then, if this is such a problem in the Middle East? And now you know what it is, how do we cause it? If I had a lot more time, we could go through some other distinct causes. But the heart of all of it, the most important variable, is insulin itself. It might seem a little strange, but it doesn't change the fact that too much insulin in the body causes insulin resistance. But then you can see how it starts to feed forward, right? Because you accurately just answered my subtle question. If you're insulin resistant, the body makes more insulin. But then that drives the insulin resistance, which drives the body to make more insulin. But it all starts with lifestyle. We live a lifestyle, a poor lifestyle, that starts to increase our insulin. That then induces the insulin resistance, which starts driving the cycle. So too much insulin causes insulin resistance. And I'll show you some data to support that in just a moment, if you're skeptical. And I don't mind if you are. All right, so one fundamental principle in the body is that as insulin is climbing up over time through poor lifestyle choices, the body's sensitivity to insulin is starting to diminish. Insulin isn't working well. So this is that simple paradigm. Too much insulin is causing insulin resistance, or a reduced sensitivity to the hormone insulin. What are the consequences? So what? Why would I have devoted the last 15 years of my life as a scientist to studying insulin resistance? I only have time for a few things. So we'll just talk about what I would consider the trifecta, the three most relevant concepts. I'd already talked about diabetes, how insulin resistance or type 2 diabetes is insulin resistance. So let's just take a few moments to go through how insulin resistance is at the heart of too much body fat, how it's at the heart of heart disease, and even at the heart of some cancers. Now, I'm not talking anything, I'm not making any bold claims here. I'm simply explaining the etiology or the background, the progression. In certain cancers, insulin resistance is known to play a role. All right, now let's go through these quickly. And as I go through them, I'll mention whether the problem is predominantly a problem of too much insulin, or a problem of insulin resistance, or insulin not working well, or both. Body fat. This is a problem of too much insulin. Let me make this perfectly clear, and I'm going to use bold terms, because as a scientist, I have asked myself, I have a hypothesis. All states of obesity in every organism, now it's funny thinking of a fruit fly as obese, but yet we still see the same thing there. Any organism from fruit flies to humans and everything in between, you cannot make a fat cell get big unless insulin is elevated. Similarly, you cannot have a fat cell shrink unless insulin is low or basal. It cannot happen. Insulin is the hormone. It dictates the use of energy in a fat cell, and any other cell, mind you. It will control. It has its hand on the throttle. It's controlling the rate at which a fat cell is growing or shrinking. This is a fundamental biological principle. Insulin is in charge of the fat cell. If you're not controlling insulin, you're not controlling fat. Body fat. This is not even remotely a new idea. From the mid-1800s, we've known that certain foods are affecting insulin. Even before we knew what insulin was, we knew that there was something happening affecting hormones in the body that would create an environment that was either pro-fat gain or pro-fat loss. But it all has to do with insulin. In fact, Wilhelm Folta, an Austrian scientist, physician, he said it best. There is something fundamental in the pancreas that is responsible for fat gains. And of course, that one thing that the pancreas is making from the islets is insulin. Now, let's look at type 1 diabetes. I hope you're physicians mostly. Most of you here are physicians, so this will not at all be offensive. This was the first type 1 diabetic in the U.S. treated with type 1 diabetes. I say in the U.S. because it's my one moment of Canadian pride. Insulin was a Canadian discovery and first used in Canada. That's our one contribution. She hadn't been taking insulin yet. She just was diagnosed, but it's a very common feature in the untreated type 1 diabetic. This is not type 2 diabetes. This is a disease of too little insulin. The cells in the pancreas that would make insulin don't work anymore. And what happens as the person's insulin is really low, they just start to lose all their fat because the body cannot hold it. And of course, that's not healthy. We need fat. We're supposed to have body fat. We need it. She doesn't have any because there's no insulin to tell the body to keep energy and store it as fat. Now, what happens within just 4 months of taking insulin? But what's more remarkable, and I'll show you this again in just a moment, is that what happens in the type 1 diabetic as they start taking insulin, when they gain fat, they eat less. They suddenly stop eating sooner. They have more control over appetite because insulin is involved in appetite in the brain. So she's eating less, but she's gained fat. Now, a wonderful amount of fat. She's a delightful little girl, but she gained body fat just because now she had the molecule that lets fat actually grow. Let's go another example. This is an older woman, type 1 diabetic. This is her midsection. Her knees would be down here. So these are her thighs. And look at those. Those are not her knees. They're not tumors either. She's a type 1 diabetic. What do type 1 diabetics have to do all the time? They have to inject insulin, right? And we tell type 1 diabetics to do what when they inject insulin? We tell them to rotate their injection sites, right? They might do it on the legs, on their rear, on their arms, anywhere. But they rotate it. Do you know why? To prevent that from happening. These are fat pads. She's been injecting her insulin only in her thighs for her whole life. And so that has made those fat cells get all of the insulin. And so they got all of the size effect of the insulin. Now that seems kind of bad, right? But she could hide that easily enough. Mind you, if she started injecting other places, that would start to go down again because that's unnatural. Insulin's driving that fat growth. But look at this guy in the UK. This was called, in the New England Journal of Medicine, they called this belly bottom syndrome because, of course, his belly looks like a different body part. So he had been injecting his insulin only in this part around his abdomen. And look what it did. That much insulin in that one little spot drives fat cell growth. Again, I'm trying to convey to you the idea that insulin, and because insulin resistance is a state of too much insulin, that's driving fat growth. Now, this has all been type 1 diabetes, but let's look at the far more common around the whole world, certainly the Middle East, type 2 diabetes. This is a study that took type 2 diabetics from month 0, and they had just been assigned insulin therapy. And so they followed them through month 6. Now, let me just take a moment. Stop looking at that for just a sec. Insulin therapy, the physician will usually prescribe insulin therapy to the type 2 diabetic when the patient's own insulin, despite being higher than normal, they're so insulin resistant, they can't make any more insulin, and what starts happening with their blood glucose? It starts to climb. And so the physician, looking at type 2 diabetes as a glucose problem, will say, well, we'll just give you more insulin. And so now the type 2 diabetic starts taking insulin higher than it ever should have gone normally. But it's enough to bring back glucose, right? Does that make sense? And so if the type 2 diabetic, the glucose levels are climbing, they will be given insulin as a therapy, which is terrible. I'll show you that in more detail with heart disease. I could go into statistics with cancers, into statistics with dementia. When you start giving a type 2 diabetic insulin, you're speeding them to their grave. I can't make that clear enough. We kill the patient faster by giving the type 2 diabetic insulin. And I very supporting data on that claim. So here, what happens? Month 0 to month 6, what do we see happening? So first of all, what's happening to their insulin dose? Do you remember what did I say was a common cause of insulin resistance, the most relevant one? Insulin itself. And so you see here, this is a person already with high levels of insulin. Now we start giving them more. And then what happens from month 1 to 3, month 3 to 6? They need more and more insulin. And that's because that increased amount of insulin is just causing more and more insulin resistance. Just like how an alcoholic, not relevant in Kuwait, but you can appreciate the analogy. If a person wants to get drunk and have that buzz, they need to drink more alcohol. And then they need more alcohol. Or someone who's abusing drugs, they need more of the drug to get that same feeling, whatever that high, whatever that sensation may be. The same thing is happening here. In order to get the same effect from the insulin, they need to take more and more and more. Now, what's happening to their body weight? This is in kilos, which for a Canadian and in Kuwait, we all talk metric here. So with kilos, what's happening? They gain about 10 kilograms of body fat in 6 months, which is typical. The average type 2 diabetic who begins insulin therapy will gain from around 8 to 12 kilos within around 6 months. But most importantly, they're gaining fat, and you'd think, well, they must be eating more. But what's actually happening to the amount of food they're eating? It's going down. Can you see this general trend? It's going down. So by 6 months, it's about 300 calories fewer per day than it was at the beginning. And yet they weigh 20 pounds fatter than before. It's because insulin is telling the body, any food you take in, store it as fat. And so they try to eat less. They see their waist getting bigger, and they say, I just need to eat a little less. But it doesn't work because the insulin's driving the fat growth. It would just be depriving energy from other tissues. Okay, that's body fat. Heart disease, there's so much I could talk about. And heart disease has already been mentioned repeatedly just this evening. I won't go into much detail. I will simply say this. If you have a patient who you've diagnosed with heart disease, and it could be any of these things, atherosclerosis, hypercholesterolemia, as already mentioned, coagulation, the blood clotting excessively, all of these things are linked to insulin resistance. I know there was a famous physician, endocrinologist, who said if you have a patient with, and he was a physician, just like you, not a scientist, not a boring scientist in the lab. He said if you have a patient with heart disease and you haven't diagnosed them with insulin resistance, you just haven't diagnosed them yet. In other words, all instances of heart disease almost always have at their origin insulin resistance. So when Dr. Dan showed you that wheel of death, if you will, the non-communicable disease death in Kuwait and Middle East, heart disease was the big one. Do you remember that? And diabetes was small. It's because people don't die from the diabetes complication. Oh, they die from its complications, not from diabetes. And so really, you can take the diabetes part, you can take the heart disease part, and both of those, you could have just said insulin resistance, because that's the heart of heart disease. That's at the heart of it, the center of it, is insulin resistance. In this study, just simply showed that as you have to give a type 2 diabetic more and more insulin, their risk of dying from heart disease goes up by 3 times. So a 300% increase in the type 2 diabetic who has to take the most insulin because they're that much insulin resistant. Okay, there is so much again. We could devote hours to this topic, and I do this as a professor. I'll just simply show you the most small sliver of publications that have been released on this topic of insulin resistance and heart disease. Now, last one, cancer. With cancer, it's a problem of too much insulin. Some cancers, let me be clear, and let's just look at the 2 most common, prostate and breast cancers, the most common in men and women, respectively. Again, this is a big topic. There's so much we could go into. But if you actually take samples from the prostate tumor, samples from the breast tumor, you'll see that they have significantly more insulin receptors than normal tissue. In fact, in this study done from breast tumors, they found that the breast tumor had 7 times more insulin receptors than the normal mammary tissue. And that's not too surprising when you consider that. Do you know what is the main, how do we identify where cancer is? You guys familiar with the PET scans? We infuse a radio-labeled glucose. In fact, this could have been something from nuclear medicine, for heaven's sakes, not a physiologist. But we then do the PET scan to see where is the glucose going. And cancer cells use glucose 200 times more than normal cells do. And so we see, whoa, all the glucose is going to this one particular section. That's where the tumor is. So this matters. Insulin telling the tumors to take in more glucose to feed the cancer. So you guys have probably heard the Warburg effect, named after I think the Austrian or German physician or scientist who discovered that cancer cells prefer glucose as a fuel. So do bacteria, actually. But what this means is that in this case of poor metabolic health, of insulin resistance, aka pre-diabetes, pre-type 2 diabetes, or outright type 2 diabetes, we have this so-called perfect storm. It's a terrible storm, but it's perfect for a cancer cell. You not only have a lot of insulin, which tells the cell to grow, that's insulin's effect, it is an anabolic hormone. That's why you have bodybuilders. They'll lift weights and then they inject insulin into their muscles to try to promote the growth. It's a terrible thing to do, don't do it, but it will make your muscles big. So we have insulin telling the cells to grow and divide. And then we have the fuel for that growth. Because it takes energy, of course. If you're going to tell a cell to grow and divide, it needs energy. And in this scenario, it's perfect. We have a lot of insulin telling it to grow. We have a lot of glucose fueling the growth. And so the cancer cells are just happy to be there and grow and grow and grow, exacerbating the disease. So, I'd already mentioned diabetes at the beginning. We spent a few minutes talking about body fat, heart disease, and cancer. If we had more time, like a whole semester's worth, we would go through how fatty liver disease, this is the most common liver disorder in the world, non-alcoholic. Yes, even in Kuwait or even in Utah in the US, where very few people drink alcohol, non-alcoholic fatty liver disease is the most common is the most common liver problem. And yes, insulin is too high. It's telling the liver to turn on lipogenic or fat-producing processes, and the liver becomes fat. We could also talk about certain reproductive disorders, like low testosterone in men and its connection to insulin resistance, or polycystic ovarian syndrome in women, the most common cause of female infertility. In fact, PCOS is at its core a disease of too much insulin. Too much insulin is changing how the ovaries are producing the typical sex hormones, androgens and estrogens. It's messing it up. We could also talk about musculoskeletal disorders, how insulin resistance is linked to muscle wasting. If insulin isn't working as well at the muscle, it doesn't let the muscle grow and be as robust as it should be, and so the muscle wastes. Also, joints like osteoarthritis, even that is a metabolic disease. It's not a disease of wear and tear. You can have morbidly obese people who have perfectly fine joints if they're not insulin resistant. That's not common, mind you. And then lastly, we could look at neurological health with regards to stroke, as mentioned, when Dr. Nadia mentioned this, and dementia. The most common form of dementia, Alzheimer's disease. Once again, insulin resistance is changing the way the brain uses glucose, and then the brain starts to starve. Those nerves they don't grow well, they don't operate well as they are deprived of their energy source. Once again, insulin resistance is at the middle. Now, as a scientist, I'm very careful when I make these kind of claims, and I would want you to know nothing I'm stating right now is opinion. It is all based on multiple peer-reviewed studies. So everything here, this is why I focus on insulin resistance, because you can pick a chronic disease. And insulin resistance, it might not be the cause, but it's making it worse. A genetic mutation is what's going to cause the cancer, but if you're insulin resistant, it's likely that you're going to just be feeding the cancer better. You're going to enable it to be worse than it would be. There might be a genetic predisposition for Alzheimer's disease, and there are genetic factors there too, of course. But if you're insulin resistant, boy, you're going to just push it along that much faster. The reason this is powerful is that if you're worried about your diabetes, if you're worried about your body fat or your blood pressure, it's nice to know you only need to face one thing. If you're focusing on if you're focusing on insulin resistance, you're able to address all of them. Now let's talk, one last thing, skin disorders. Acanthosis nigricans. This is a darkening of pigment on certain skin folds in the area, around the groin, the armpits, the neck. Also skin tags, little bumps of skin that you typically see on armpits, once again related to insulin resistance. So before I end, I've just terrified you, I hope. This has kind of been a horror story, but it's a horror story with a happy ending because you can absolutely change this. And so as a scientist, how do you do this? To me, the data comes back to insulin and controlling insulin. How to lower insulin, that's the key. How do you bring your insulin down in order to start improving your insulin sensitivity? There are 3 keys, 3 pillars, if you will, to make it as simple and explicit as possible. And I'll make this quick because I'm running out of time. Be starch smart. Second, don't fear the fat. That might seem a little controversial, but again, this is not my opinion. And then lastly, hurry and fast. So let's just go through these very quickly. What do I mean by starch smart? If it's a class of carbohydrate or in the class of the macronutrient carbohydrate, that's a starch. And we can look at it as good or bad. And I define a good starch as one that has very little effect on insulin. A bad starch has a large effect on insulin. Now, where would we put some common starches? Bread, potatoes, sugar, being a simple carbohydrate, those are bad. They're not good. Not at all. These are things that if you're going to eat, you need to be careful about it. And if you're not inclined, if you don't have a family history of type 2 diabetes, you can eat these a little more than someone else could. And I'm not saying never eat them. I'm just saying be smart about it. Don't eat them at every meal. Don't have a bowl of cereal followed by a bagel, followed by a sandwich, every meal being starch heavy. And that's kind of the world we live in now. You need to be smart about it. Now, the good ones, fruits and vegetables, eat them. But not all fruits are created the same. Unfortunately, the yummiest of them, because they're the sweetest, because they're the most loaded with the sugar fruit, fructose, pineapples, bananas, mangoes, those are the ones you eat less frequently than other fruits. And vegetables, other than potatoes, for example, you eat as much as you'd like. But I will say, eat fruit. Don't drink it. God didn't create the orange tree to have orange juice. We don't pluck the orange and put a straw in it and drink it, right? We have to chew through the fiber. And with that fiber comes the sweet fructose molecules. We are not meant to drink fruit. We're meant to eat it. And you drink a glass of orange juice, you just drank 5 oranges. Would you ever sit and eat 5 oranges? Never. The fiber would have filled you up long before you got to 5. So eat the fruit the way God intended. Don't drink it. And don't let your kids drink it. We sometimes as parents, and I'm a dad, I know what this is like. We want our kids to be happy. Sometimes we just want them to shut their mouths. And so we give them something yummy. And we might think, I'm giving you fruit juice and I'm helping you. No, that's making it worse. No fruit juice. All right, now what about fiber? Fiber enjoys this really lofty position when it comes to health, and rightly so. Fiber, we put that solidly on the good side, and there's a lot of evidence to support that. I will mention, be careful where you get your fiber. And this isn't my intention to make a plug for Unicity fiber. It's a very good version of it. You need to be careful when you do pull a fiber off the shelf. The most common fiber supplement in the US and Canada, the second ingredient, can you guess what it is? It's fiber, number 1. Second, sugar. That's not going to help. So make sure you're aware of what's coming with your fiber when you get it. All right, second one, don't fear the fat. This is the one that might upset more of you, but I'm sorry if it does. I hope it doesn't. When we look at the 3 macronutrients, macro meaning these are the big substantial parts of an animal's diet, of a human's diet, fat, carbohydrates, protein, and we look at what it does to the insulin release, how it affects insulin in our bodies. If you give a human a tablespoon or a certain amount of pure protein like whey or casein, you get a modest insulin effect. About 2 hours, 90 minutes, 2 hours, you've about doubled or tripled the fasting insulin levels. Now what happens if you give them pure glucose? You're increasing it to about 12 times. And so insulin increases dramatically. Now, that's not entirely fair, because if you were to eat something like cauliflower or broccoli, that's not going to have the same effect as, say, sugar will, or chocolate or something. Although if it's pure chocolate, it's wonderful. It's just we put so much sugar in it. So carbohydrate has a huge effect on insulin. Now what's the last one? If you give a person pure fat, For example, you have a drink and you put in coconut oil or something like that. What will it do? Can you see it? Did you even see it come in? You can't really. It's hard to see because it doesn't do anything. Insulin stays the same. The reason that matters is that all of a sudden when you've eaten fat, you provide fuel for the body. You've given the body energy to feed muscles, to feed nerves, you name it, joints. But because insulin is low, what are you not feeding? Remember the fat cell. Insulin has to tell the fat cell what to do. And so oddly enough, you're eating fat, and it's the one thing that's making sure your fat cell won't get big. All right, so what kind of fat? If I'm telling you not to be afraid of fat, the fruit fats are dynamite. Olives, avocados, coconuts. We have been, as a species, we've been eating them since the very beginning. Because all we needed to do was take the fruit and press it, and we would get the oil out of it. It didn't need any chemicals. It didn't need any machines. It was just our own brain pressing it, and we got the oil and did whatever we wanted with it, including eating it. And animal fat. Fruit fat and animal fat are the two fats, once again, as a species, we have grown up on. Since the very beginning, whenever it was, however it happened, we've been eating fat from the very beginning from animals and fruits. The newer oils are the ones to be afraid of, and trans fat always avoid. And that's man-made. We've done it. All right, last one. Hurry and fast. What do I mean by this? This is an appropriate topic in this part of the world. I mean this idea of having a break from food. The way I typically define this is also known as time-restricted feeding. What you do, you simply compress the period of time when you're eating. Every single day, you avoid food for 12 hours overnight. For the healthy person who can do this, maybe your last meal is at 7 p.m. You don't eat again until 7 a.m. You can drink other things. Don't drink juice, please. And I'm not telling you. I'm just giving you, this is what the evidence supports, mind you. I'm not your physician, so I'm not giving you a prescription. What I recommend and where I've seen tremendous benefit. And then from time to time, every couple times a week, miss a meal. Skip either breakfast or skip dinner. Now, make sure you eat a good hearty meal for the meals you are eating. You don't have to count your calories in this regard. You just are trying to prolong the period of time without food so you can keep your insulin levels lower longer. And then every once in a while, maybe about once a month, you do a full day food fast. Might seem tough at first, but you'll get used to it in no time. So what does this look like? If we look at time during the day and the concentration of insulin, the typical person who's eating all the time, very starchy, low-fat meals, they're going to have substantial insulin effects throughout the day. Unfortunately, it takes insulin about 2 hours to come down. 2 or 3 hours, what happens? They eat another starchy meal, and insulin comes right back up. So you can see that almost all of their waking time is spent in a state of elevated insulin, feeding fat cells, feeding the potential for cancer growth, feeding liver fat accumulation. Now with time-restricted feeding, very simply, you've just, in this case, missed breakfast, which is the one that I find the easiest to do. And what we've taken was what was this whole day insulin increase, we've now diminished it to just part of the day. And so the food we're eating has less effect on promoting the negative consequences of too much insulin. So this is what we went through in the time that I had. And now it will be time for questions, but they're coming up to Dr. Dan, and I would just be thrilled to answer any questions that you might have. Thank you for your time.